I welcome our department, Disposing sir, under whose guidance unit of play variety is blossomed. I welcome this committee, HCMU, Professor Nodal Officer, and this committee and parents. I also welcome Professor Officer, faculty in Department of Anesthesia. I also welcome all the participants in this webinar. As we all know, cancer burden in the society is immense and it is growing very fast. In a recent review, around 65% of the patients with advanced cancer report pain. Out of these patients, 60% of the patients under treatment also report pain. And it is surprising that 1/3 of the patients who have been cured from the disease experience pain after their curative treatment. The major barriers in the world is the adequate access to the opioids where pain is not adequately controlled. But even in those areas where opioids are available freely, pain remains prevalent in the patients of cancer. So it is very important that poor pain control impacts patients' life in such a way that it increases psychological distress, decrease in social activities, and impair overall quality of life of the patient. Here comes role of palliative care, which increases patient satisfaction. So, this webinar is organized to emphasize the role of opioids, morphine in cancer pain management. I would like to invite our head of department, Professor G.P. Singh sir, for the welcome address. Sir, please.
Thank you, Dr. Manish. Good afternoon to all of you. Honorable Vice Chancellor, Lieutenant General Vikram Puri sir, Dr. Raj Gopal, Chairman, Palladium India, Dr. Arun Chaturvedi, Professor and Head, Surgical Oncology, my colleagues in the department, Dr. Monica, Dr. Sarita, Dr. Manish, Dr. Ajay Chaudhary, delegates, ladies and gentlemen, I extend my warm welcome to all of you in this webinar, role of opioids in cancer management. General Puri has given new directions, new ideas to the university today. He is completing 1 year of his successful tenure in KGMU. I want to compliment him for his successful tenure and hope he will raise the university to newer heights. Under his guidance, oral morphine has been available in KGMU. Thank you, sir, for your able guidance and hope you will be guiding further. Dr. Raj Gopal, sir, is founder, father of palliative care in India. Because of his dedication to the patients, he has been awarded Padam Shri by Government of India. As we know, cancer is initially painless disease, but as it advances in terminal stages or in between, there is sometimes very painful conditions. Opioids are good analgesics, but problem with opioids is dependency and addiction if it is used for prolonged time. Since in cancer patients it is given in terminal stages, we want to relieve agony, pain of the patients, so we don't bother about dependency or addiction. Here I would like to quote, General Puri sir must be remembering film Anand, where the Rajesh Khanna is saying, Babu Moshai, Zindagi badi honi chahiye, lambi nahi. Matlab, quality of life should be good. Quantity doesn't matter. So by using opioids, we are relieving the pain of cancer patients. With these words, I welcome you all again. Thank you very much.
Thank you, sir, for your kind words. Now, I would like to invite Professor Monica Kuliman to say a few words. Ma'am, please.
अनम्यूट करिए डॉक्टर मोनिका, आप अनम्यूट करिए, आप म्यूटेड है.
Namaskar, everyone. Honorable Vice Chancellor, sir, and the head of department, all friends, Sarita. It's a privilege to be with KGMU, at least virtually. It's many years since I have visited your wonderful campus with so much of history and so much of compassionate care happening. I have worked with you for a period of 3 years with one project that was up and running about 15 years back. But I'm so happy to be with you again. The subject is specifically on opioids, but to set the context, I would like to mention an ethical compromise that's happening with healthcare in our country, which is already mentioned in the introduction. Health is defined as physical, social, and mental well-being. Well-being, physical also. And also, do we know what is the duty of care of a doctor to a patient? What is my duty of care to my patient? In many countries, it is defined by law, not in India. But the Indian Council of Medical Research defines it thus. The duty of the healthcare provider is to mitigate suffering. Just note that one sentence. The duty of the healthcare provider is to mitigate suffering. They also add it's to cure sometimes, relieve often, and comfort always. Then they add one sentence. There is no exception to this rule. Nothing is an excuse for us not to try to mitigate suffering. But having said that, in India, less than 4% of people have access to pain relief. 96%, ladies and gentlemen, we are leaving the suffering of pain unalleviated. And especially to the senior doctors would know this already, but if the young doctors have not grasped this one point, I'm not going to talk about high neurochemistry or pharmacokinetics. This simple fact that pain can be beyond your imagination. In our palliative care unit, every year at least 3 people come to us with a scar around the neck. The latest was a man with a non-cancer pain. He had a post-herniorrhaphy scar pain, which went on worsening, so much so that he attempted suicide twice. And his daughter had to stop her studies because there was no money. The son left his job and came back and started doing odd jobs. The whole family is wiped out. The failure to alleviate pain and suffering is an ethical failure on the part of the healthcare system in our country. But I am glad that institutions like KGMU are taking some steps, are taking the lead in alleviating pain and suffering. So, particularly happy to be with you on this occasion. I shall, what I propose to do is talk about the initial part. I'll talk about pain management in relation to opioids. And in that context, please pardon me, I'll go on to some foundation measures for use of opioids. And then we'll go on to oral morphine, very basics. Please bear with me because I am sure there are junior doctors there. They also need to know. I'll go to the basics of oral morphine therapy. Then we'll talk about what do we do when oral morphine does not work. With your permission, I am sharing my screen now. Is my screen visible now?
Yes, sir. Yes, sir.
Okay, thank you. Let us start with the story of this man. 35 years. Squamosal carcinoma, upper lobe of right leg. Deep-seated gnawing pain in the right suprascapular and infraclavicular areas. He is unable to sleep. And the body language of the man and his wife sitting there with his chin on her hand and staring into oblivion. That's very telling. This is how the International Association for Study of Pain defines it. That it's a sensory and emotional experience. I'll ignore the rest of it, all the complicated wording. But the most important thing to remember is that it is also an emotional experience. We all, for the same stimulus, our experience of pain is bound to be different between the Dr. D.P. Singh and me and Sarita and somebody else. We have a right to be different. It will also depend on our emotional status at that moment. If somebody seems to be unreasonably overreacting, in our opinion, to pain, let us remember that we have no right to stand in judgment. If there is a psychological reason or a social reason why that pain is worse, it's up to us to find that. Pain cannot be managed only by interventions like surgery or nerve blocks or by opioids or other medicines. Pain will also need humane treatment of an assessment and treatment of psychological and social factors also. But now I am going on to just this tiny bit of neurophysiology. Not a lot, I assure you. Before I go on to this description, let me ask you, when I move my cursor, are you able to see it at the bottom of the screen? Can
yes,
somebody
we can see it. Yes.
Thank you, sir. Thank you. So let us use this oversimplified pain pathway. When you prick your finger with a pin to draw a sample of blood or to do your blood sugar, you are stimulating that stylus or pin or whatever it is stimulating the nerve ending, the nociceptor. We like complicated words, so we'll call it nociceptor. The receptor at the nerve ending that senses a noxious stimulus, which that electrical impulse is transmitted via the peripheral nerve to the dorsal horn of the spinal cord. There the impulse gets modified, crosses over and goes to the brain. At the thalamus and cortex, pain is appreciated. But reflex responses will happen at the spinal level itself. For example, muscle contraction. You know how many of you, 1/3 of you must be having a thickening of the muscle at the shoulder because of the continuous stress and the way human beings are made with a curvature of the spine. That happens at the spinal level itself, but appreciation of pain occurs at the the thalamus and cortex. I'm not going to more complicated things. We are not going to talk about the various receptors. We are not going to talk about the pathways because there is a reason why I mentioned so much. We'll come to that. This is necessary for our understanding of opioid action also. I have a question for you. If the stimulus is constant, so okay, in this man's case, I showed you the 35-year-old man. Suppose, just for argument's sake, imagine that his cancer in the upper lobe of the lung is remaining constant. It is not growing, it is not regressing. If it remained constant, would the pain remain constant over days or weeks? Or will it decrease? Or will it increase?
It might increase.
Increase.
Thank you, doctors.
Increase.
Almost always it will increase. Why I say almost always is, if it is a mildest pain, which doesn't cause you any anxiety or major inconvenience, like your neck pain, you just rub your shoulder and continue with your work. So if that kind of thing may not increase when you have emotionally adapted to it, but any severe pain will increase. I am sorry to the seniors again. I am explaining the mechanism also a little bit, because it's very important that if there are postgraduate students, they and young doctors must understand this. This occurs, this increase that you both mentioned, why it increases is due to several reasons. One is at the nociceptor, because the body, if the stimulus is remaining constant, tries to give you more and more pain, because body is protective. It's giving you a warning. It's telling you, run away, protect yourself. So, one of the ways in which it does is, it causes sensitization and recruitment at the nociceptors. That means, silent or sleepy nociceptors get recruited. So, as time goes on, there are more and more nociceptors which are also sensitized to sense the pain. So the electrical impulses going from here will keep increasing even if the stimulus is constant. Does anybody want to ask a question, or can I move on? Okay, I'll explain this also, and then I'll take questions if any. You see the spinal cord here. This is the dorsal horn of the spinal cord. Two things happen at the spinal level. One, the area of pain keeps on increasing. Adjacent spinal segments get recruited. Doctors, you see this in the emergency room. A patient comes out with a fracture of the rib. You ask, where is the pain? And they point exactly to the site of pain. You go on rounds tomorrow and ask, hey, how is the pain? They say, the pain is over here. They will show an extended area. That's because of recruitment of adjacent spinal segments. But the most dramatic change happens at the dorsal horn. And this is called sensitization. It is called central sensitization. This was peripheral. Central sensitization. It's also called the wind-up phenomenon, like a spring being wound up. So when this has happened, the same number of electrical impulses going from the periphery will cause an increasing number of stimuli, to electrical impulses, to go to the brain. Today, if 10 go from here, 10 go up from here to the brain also, but tomorrow it will be 100. Day after tomorrow it may be 1,000. It will keep on increasing. And unfortunately, as time passes, the dorsal horn will lose its normal architecture. Its laminar structure gets destroyed. That is when you get abnormal sensations in the area of pain, like hypoesthesia, hyperesthesia, dysesthesia, allodynia, etc. So what have we said so far? There's a reason why I am explaining this business of central sensitization as well as peripheral sensitization recruitment. Important point. If you leave pain untreated, if the stimulus remains, the pain will keep on increasing. So much so, it will even destroy the normal architecture of the central nervous system. And thereafter, treatment will be harder. So what is the clinical significance? Why did I bring up all this confusion? Would any of the postgraduate students listening to this like to try to answer the question? What do you think would be the clinical relevance of this process of sensitization and recruitment? If not the PGs, just anybody? The clinical relevance. Treat pain early. First message. Treat pain early. If you delay it, the pain is worse. You will need more medicines. And the pain may not easily go off. Treat pain early. This is why we are advised to give preemptive analgesia. For a major surgery, put in an epidural even before the surgery, before anesthesia, so that these changes do not happen. Treat pain early. And the second message is, if pain is constant, will you give your analgesics at a regular interval or SOS? In all continuous
Regular interval.
pains, in all continuous pains, analgesia must be by the clock, depending on duration of action of the drug. SOS is not acceptable. Ladies and gentlemen, you may be cutting open my chest for a surgery tomorrow. I have a right to pain relief. I must have pain relief. That's my right. It's your duty to relieve my suffering. And if you have done a thoracotomy, the pain will cause me a lot of suffering. It may also predispose to pulmonary complications. Therefore, if possible, start analgesia before the preemptive analgesia. If not, give me analgesics by the clock. If it is paracetamol, you give it me 6 hourly. If it is ibuprofen, give it to me 6 to 8 hourly. If it is immediate release morphine, give it to me every 4 hourly, and so on. I'll also tell you about not all the classifications. Especially we are going to talk about cancer pain. So I have to be, this is important. This man with a pain in the right infrascapular and right infraclavicular area, most probably has a nociceptive kind of pain. His nerve endings here are getting irritated by the stimulus, by the tumor, and he is getting the pain. But tomorrow, if his tumor invades up, encroaches onto the brachial plexus, where will he feel the pain? The pain is likely to be appreciated in the right upper limb. There is no pathology in the upper limb. That kind of pain causes because abnormal impulse generation in the nervous system, and a pain caused by abnormal impulse generation in the nervous system is called nociceptive pain. Neuropathic pain. Now, why am I saying this? Unfortunately, neuropathic pains are relatively less opioid sensitive. I won't say they are not opioid sensitive, but less opioid sensitive. And they cannot be handled by just giving them morphine. You may have to use adjuvant medicines also. How you diagnose neuropathic pain? Unfortunately, there is no diagnostic investigation. It is clinical diagnosis. Burning, shooting, lancinating, etc. likely to be the descriptions. Pricking. But most significantly, the distribution will be in the area of distribution of a nerve or a group of nerves or on dermatome. That distribution will give you a clue, and if it is long lasting, you may find abnormal sensation in the area of pain. So before you dispense opioids to any of the patients in your pain clinic, you will give a thought to what kind of pain is this. If it is nociceptive, okay. If it is neuropathic, you may have to add on adjuvant medicines for neuropathic pain. This is the World Health Organization's 3-step analgesic ladder. You will notice that in step 1, we do not have opioids. We use non-opioids with or without adjuvants. Adjuvants are, what are adjuvants? Adjuvants are painkillers which do not have an intrinsic significant analgesic activity, but which in a particular context will confer analgesia. For example, tricyclic antidepressants will confer analgesia in neuropathic pain. Anticonvulsants may cause membrane stabilization. Tricyclics will inhibit the reuptake of serotonin and norepinephrine. Or why? Many of you must be parents in this group. When your child cries out with abdominal colic, what will relieve the colic? Dicyclamine or hyacinth-butyl bromide. They are not primarily painkillers, but in a colic, you have to give it to get analgesia. So those are adjuvant drugs. So, ladies and gentlemen, in the first step, we use non-opioids with or without adjuvants, and then only we go on to the opioids. Now, I will say that any other measure that you may need, we may have to use at this stage. Nerve blocks, non-pharmacological treatment, psychosocial support. Nerve blocks, some people call it step 4. That's not fair. If I am in pain, you think I'll get it benefit from a nerve block? I want it now, not after you have gone through 2 weeks of trial with the ladder. So that's a sort of umbrella that we will use. But remember, step 1, non-opioids and adjuvants are the foundation. Even when you are using your opioids, you continue the non-opioids and adjuvants. By doing that, you will improve the quality of pain relief. You will reduce the side effects of opioids. I have a few slides here on non-opioids, which I may use in the time of discussion. I'm not going into that now. Paracetamol, etc. But now I am going into the principle of balance. Principle of balance says that as a doctor, you and I have a dual responsibility. We have a responsibility to relieve people's pain, but we also have a responsibility to prevent inappropriate or non-medical use. See, very often in discussions at guideline development, etc., there are two sides fighting with each other. The addiction medicine people saying that opioids should not be used. The palliative care and pain physician saying that opioids are necessary. There has to be a balance. That's the principle of balance. We have to use opioids to treat pain because for 2/3 of cancer pains, nothing else will work adequately. You need them. But we have to learn to use it without contributing to inappropriate or non-medical use. In MP, UP and Rajasthan, 3 states in India, opium is grown under license by farmers, and farmers are obliged to sell all their products to the government opium and alkaloid works, which are there in Neemuch and Ghazipur. So where does the morphine come from? Individual manufacturers obtain morphine powder from this factory, from the government factory. There is only one source. And they get it, they make the injections, they make the tablets, everything. A few things that we will remember when we order the morphine and start using it for those who are not familiar with it. Can morphine kill? Given in cancer pain relief, morphine can kill by causing constipation. Let us not underestimate constipation. Constipation can be a horrible side effect. Almost everyone will get constipated if you give it by the clock. Has to be actively treated preferably by stimulant laxatives like bisacodyl or Dalcolax. Nausea and vomiting will happen roughly in about one third of people for the first few days. Our routine in our institution is, if they are not on opioids already, we start them on antiemetics for 3 days. We'll give them 10 tablets of metoclopramide, ask them to take it 3 times a day for 3 days and stop. Almost everybody will be fine. Up to one third of people will also be a bit drowsy. Most people may not be significantly drowsy. We had a bank officer who continued to work for 9 months on morphine. We had an architect who continued to work for 2 years on morphine and finished his project. So sleepiness does happen about one third of people, and that may need special attention, but majority will be okay. Urinary hesitancy may occur maybe up to 7% of people. That is not absolute statistics and may need active treatment. And rarely people may have pruritus, which won't be responsive to antihistaminics. Please make a note of this. Pruritus with opioids are unlikely, I'm not saying no, but unlikely to respond to antihistaminics. So your usual cetirizine, etc. will not work. And strangely, that seems to respond to ondansetron in doses of 4 to 8 milligrams a day. That may significantly relieve the pruritus with opioids. Pruritus is rare with oral morphine, happens more often with neuraxial administration. So it will be a good practice to remember ondansetron in the context. Of course, remembering that ondansetron will also contribute to constipation, which will need then to be aggressively treated. Here is a question. Are opioids analgesics addictive? So the answer is, well, if you insist on one word answer, I will say yes. But in the context of cancer pain, if they are used with reasonable care and precautions, the chance of addiction is remote in cancer. Whereas in non-cancer pain, addiction is a possibility if it is long-term. Let us not club all non-cancer pains together. If it is a peripheral vascular disease, you may have to use it with adjuvants. There is no other choice. Whereas opioids in something like a low back pain, for example, should not be a first-line long-term analgesic. I'll share this presentation with Sarita, so that anybody who wants to go deeper into it will have the references that I am adding. A bit about dependence. All opioid dependence is not addiction. If you give it for a long time, especially more than 3 weeks, many people will get dependent on it. That's physical dependence. If you suddenly withdraw it, they may get disorientation, they may have myoclonus and delirium, abdominal cramps, diarrhea, and so on. That doesn't show that they are addicted. This is easily treated by a gradual withdrawal. We do it. Sometimes they get radiation, the pain goes off, we withdraw it. Whereas psychological dependence is addiction as manifesting as a craving for the opioid. Doses keep on increasing. Somebody who is addicted will never be satisfied with the same dose. Their dose will keep on increasing. And after some time, their minds will have no space except for procuring opioids. They will lose interest in everything else. And they'll come and say, "Oh, doctor, I'm so sorry. A pickpocket came and stole my opioid. Or a crow came and snatched my opioid," and so on. This is to be remembered. We have a duty to prevent this. So in chronic non-cancer pain, opioid should not be a first-line drug. When you have to use it, always explain. You run a risk of addiction, so we'll have to follow some rules. Here is a contract that you and I are entering into. You will never use more than what I prescribe for you. And if you in the midweek come and say, my drug is over, please give me more, no, we will not give it. And you should not try to get the medicine from two places at the same time. So you will also possibly ring up your friends in SGPG AMS and ask, hey, listen, let us have this clarity that any patient coming from us we should not entertain people requiring morphine for non-cancer pain. They should be allowed to take it only from one center. But now the bad news. Only about 3/4 of all patients will have good pain relief with the WHO analgesic ladder that we have described so far. I have not talked in detail about weak opioids or tramadol and strong opioids like morphine. The side effects are the same. The dependence is the same. Now, if morphine, you use all this ladder, everything, and still 1/4 of patients may not get pain relief, what do we do for them? We have to prepare ourselves by believing the patient about the pain. Let us not make excuses for our failure to relieve pain. We accept that we have not relieved their pain. To look again, are there any correctable factors? A pleural effusion may be happening, and that may be why this man's pain is not going away. That needs to be tapped. And if his rib is eroded, he needs palliative radiotherapy, and so on. And thirdly, see, okay, you have given your medicines. Has he understood how it is to be taken? Are they following your prescription religiously? And ask the question without being non-threatening. Hey, are you taking the medicines? And they'll say, हाँ, sir. If you get the truth out of them, then you will find that many problems can be solved. And review the type of pain. Does the patient have a morphine insensitivity kind of pain? And is there a psychosocial issue worsening the pain experience? What's the family background like? Is that causing a worsening of the pain, the emotional consequence? Have we been too drug-oriented? Can we try something else? Maybe a celiac plexus block? Not for the pain in the chest, of course. Other non-pharmacological measures? Have we been giving our drug therapy has been optimal? These are things that we check. But if once that checking is gone, we will have to think of switching the opioid. Because many of those 1/4 of patients may respond to other opioids than morphine. Right now, I do not have the time to explain why that happens. If we have time during the discussion and if you want to know, we will come back to that. But if it is not working, we have to think about a opioid switch. Let me tell you that only 3 drugs are available in our country for step 3. Morphine, Pendanal, and methadone. And let me tell you, it is fearfully expensive, 100 times more expensive, but it's not a good first-line drug. Morphine is easy to titrate to find out how much the patient needs. You can't do that with fentanyl transdermal. Parenterally, you may be able to titrate, but not transdermally. So when is it good? If the patient is rich, and if you have achieved good pain control with morphine, then you can convert the dose and switch to transdermal fentanyl. But ladies and gentlemen, please remember, I have given the reference here. This paper was published in 2018 by 3 Indian authors in British Medical Journal. And they find that 55 million Indians are pushed below poverty line. by catastrophic health expenditure every year. If you are treating the pain effectively, but you are destroying the family and wiping out the next generation, aren't you destroying health? Before you pick up your pen to write that transdermal Pendanal, please think again. But then what will you do? If an opioid switch is needed, there is something. It is 3 years since methadone came into the market, Indian market. Methadone is sold only by one company. I am shamelessly promoting this. Please believe me, I do not have shares in the company. And it is inexpensive, even more inexpensive than morphine. Morphine, at least in Kerala, is very inexpensive. Other companies sell it for 3 to 5 times more cost. But this is even less expensive. 3 years it has been there. Now it is available. We had tablets earlier, but the sales were so low that the company is now making only syrup. It is inexpensive, but you cannot just prescribe it the way you have been prescribing morphine. You need to understand this. Please contact us, anybody. We promise you that we will be responsive. We would like to work with you. Methadone has to be made available. In any pain relieving facility, methadone has to be made available, because 1/4 of patients with cancer, pain, and many more with other conditions will not get good relief with morphine. You need this. It is an ethical imperative. Ethically, there is no justification for not getting methadone. The same NDPS rules apply. If you can get morphine, you can get this also. But the margin of safety is lower. Cardiac arrhythmias and other problems can occur in high doses. So, and it takes longer to titrate. You can increase the dose of morphine every other day. Here you'll have to wait for 3 to 5 days. So, but ladies and gentlemen, we will work with you. I have given the email ID here about procuring your opioids, documenting its use properly, about reporting to drugs, giving periodic reports to drug controller. That's mandatory every year. And about procuring methadone, etc. Please note our email ID. We stand by. My organization, Pallium India, is committed to integrating palliative care and pain management throughout the country. It will be a privilege to be of assistance if we can be of help. Yes, I have finished my time of 40 minutes given to me. I am sure there will be many questions. I'll stop my screen share and wait for your questions.
Hello.
Somebody's voice is breaking. You are not audible, ma'am.
Hello, can you hear me?
Yes, Monica ji.
Yes, sir. Good afternoon, sir.
Good
Sir,
afternoon.
actually, I wanted Sarita to ask our Vice Chancellor to say a few words.
Look, have the question and answers first.
I think, sir, we wouldn't waste your valuable time. We'd like you to speak, and then we'll take the questions later on.
Okay. So thank you very much. It's been just such a fascinating session till now, and let me begin with deep respect for our Padma Shri Professor M.R. Rajgopal, the chairman of Pallium India and the father of palliative care in India, Professor G.P. Singh, of course, my head of department of anesthesia at KGMU, chairpersons, Professor Arun Chaturvedi, the head surgical oncology, and Professor Monica Kohli, Professor Sarita Singh, and her team, very dynamic team, looking after pain management, faculty, all the delegates who are joined up for this very fascinating webinar. Students, ladies and gentlemen, my compliments to the Department of Anesthesia for organizing this very unique webinar. I sincerely believe in a growing awareness today as far as pain management is concerned. The problems of end-of-life, palliative care, quality of life issues, all of this perhaps is now increasingly being understood, and there is an intense sensitivity towards these patients today. And I think towards that end, this seminar is trying to provide with that much of awareness, trying not only awareness, but trying to make you understand pain, the nuances of pain, and how a step-ladder approach, which Professor Rajgopal very beautifully, very succinctly tried to articulate. And I have to say this, it was a masterly exposition of trying to explain it in such a succinct, in such an easy way, trying to make everybody try and understand what exactly. Well, friends, ladies and gentlemen, let me say this, that besides, of course, it being multidisciplinary, I'm talking of palliative care, besides being multidisciplinary, the whole concept of end-of-life care has changed in recent times. And there is an increasing awareness about end-of-life care, quality of life issues. Let me just try and tell you that when I was the Director General, the Armed Forces Medical Services, the three chiefs, Army, Navy, and Air Force, called me for a similar problem. The problem was that even in the forces, it's not only I'm not talking of the soldier at large, but also they have parents, they have brothers, they have sisters, they have relatives who require end of life or quality of life issues and care. Now, with that in the ambit, I was asked in case we in the forces could provide centers to provide palliative care. And as some of you would know, we made one such palliative care center in Delhi, in the base hospital. We made another one in Calcutta, which is the Eastern Command of the Indian Army. And then it was like setting the cat among the pigeons. All the commanders would contacted me and they said, we want a similar sort of palliative care in all the commands. The point that I'm trying to make is there is an increasing awareness of quality of life issues, and towards that extent, I think pain relief continues to be the single most important determinant, denominator, so to say, as far as quality of life issues is concerned. Well, I'm aware that like some I think he talked about it, that in the 1980s, when hospices care was reworded as palliative care, and that it was at that time the international community recognized that there has to be this unified approach, and that is what Professor Rajgopal was talking about, the three-step analgesic ladder. And I sincerely believe that that concept in recent times has got consolidated. And well, I also must say this, that there is a huge gap in what we want, what we are saying, and what we can actually do. What I'm trying to say is that there is, as many as I'm told, as many as about 40 million people are in need of palliative care at any point of time across the world. And unfortunately, about 78% of them live in low and middle income countries. And therefore, how many of them can actually derive that sort of care is basically a question. I'm told the numbers are as dismal as 14%. It's about 40% can get some sort of palliative care, and that's, I think, it's somewhere, there's a huge demand-supply deficit, which really is a cause of concern. Well, as Professor Rajgopal said, palliative care is every human has a right to have it for health and therefore to relieve his pain. And I think towards that extent, we as doctors, as healthcare professionals, with increasing awareness, with increasing sensitization, I think there's a need for us to focus in this direction more and more, try and do whatever we possibly can as far as I'm sure national policies, programs, resources, training on palliative care among healthcare professionals will ensure in time to come and will integrate this aspect of pain relief as a part of our overall care of our patients of advanced metastatic disease or advanced cancer. I'm sure this seminar, this webinar is going to strike a chord with many of us who understand, who have been clinicians, who have treated cancer in its varied dimensions. And I once again acknowledge the efforts of Pallium India, which is a national registered charitable trust formed, as I'm told, as early as 2003. And Pallium India has strived over the years to alleviate health-related suffering by demonstrating, educating, facilitating, integrating palliative care into mainstream healthcare. So once again, to Professor Rajgopal, a big salute to you, sir, for doing whatever you did, a lifetime of sheer dedication with such great passion. I once again thank all of you, Professor G.P. Singh, Professor Sarita, for giving me this opportunity, Professor Monica. Thank you very much, all of you, and I wish you all a wonderful webinar. Thank you, and Jai.
Thank you, sir. Thank you for your valuable time and giving us your blessings and motivations. Yes, of course, palliative care is the need of hour. Due to increasing number of cancer patients day by day and suffering of cancer patients in their advanced stage of the diseases, these patients require a holistic approach to relieve their symptoms in the form of physical, psychological, social, and spiritual aspects. For these, we need a proper palliative care setup, but unfortunately, the most of the institutions are lacking in palliative care setup. They are also lacking in the proper teaching, training program, and awareness about the palliative care. But we are very fortunate, sir. We are leading under your guidance. We are providing certain small amounts of palliative care services. I hope you will guide us further, sir. Thank you very much.
Rajgopal, sir, I have one question.
Yes, sir. I'll happily try to take the answer. The question, there are also several in the chat box. Yes, thank you.
So, in patients having cancer of lung cancer patients, so what is your advice to provide them the relief of pain?
Sir, did you say tongue or lung?
Lung, sir.
Okay. Okay, thank you. In lung cancer, the precautions that I said, one of the things that we'll always do is to look for correctable factors. If a rib has been eroded and it is causing severe pain, and especially if it is fractured, the pain will be very difficult to relieve, and a palliative radiation may be the best way. So, and as I said, an effusion has to be tapped, otherwise the dull, severe pain will continue. So correctable factors, and we will then go by the ladder. When we use the ladder, we will particularly look for, especially if it's an upper lobe lesion, look for any brachial plexus involvement. If not, it is fairly straightforward. Only nociceptive pain, no chest wall or rib cage involvement, no effusion, I'll start with, I'll give the background dose of paracetamol and add on opioids. If it is mild to moderate pain, I may be able to manage with tramadol. If it is severe pain, I'll go on to morphine. Of course, adjuvants will have to be used if there is neuropathic pain also. But I'm an anesthetist, I'm not an oncologist. And many people here are anesthetists. So one important lesson that I'll take is that I have limitations in treating pain, especially squamous cell carcinoma or any bony involvement should respond best to palliative radiotherapy. There are guidelines saying that palliative care therapy should be ideally a single fraction, and if it fails on second fraction also, not a long process, so that patient's quality of life is not compromised. So such things also will have to be considered. Sir, have I answered your question?
Yes, sir. Thank you, sir.
Thank you. Sarita, shall I take on the questions in the chat box?
Sir,
Yes, sir.
yes, sir, there are some questions.
Dr. Mahavar says nociceptive pain changes to neuropathic. Oh, Dr. Mahavar, the distinction between neuropathic and nociceptive is limited. There is very often the majority of pains have a mixture of both. Say for example, anything in the face, head and neck, easily erodes into the nerves and causes a neuropathic component also. And the other thing is, Dr. Manan Mahavar also says, changes to neuropathy. Remember what I said in the beginning? I showed you the picture how central sensitization happens. If the dorsal horn cell itself has had anatomical changes, there is a central neuropathic component coming in. So yes, first answer, very often it's a combination of nociceptive and neuropathic. And yes, a nociceptive pain eventually can cause a neuropathic element by the long-term changes in the nervous system, if not by the disease progression. Dr. Sajin Dwivedi asks, what is the protocol for disposing left pendanal dose if discontinued for patient? Dr. Sajin, in our country, the law doesn't clearly say, the rules do not clearly say what is to be done. So I'll tell you what we do. I don't know if you're talking about injection or patches. If it is injection already diluted, the leftover medicine, it's always, it's our practice. It's not defined by law. It has to be disposed of in somebody else's presence. A nurse just pushes it to the sink. If it is patches, unopened patches, our law does have a provision for taking it back in stock. The rules clearly say the leftover medicines returned by the patient, unless damaged, can be taken back in stock. In your stock register, you will make entries just exactly the way you will make entries when you get it from the manufacturer. There you will write 25,000 tablets received. Here you will say 17 tablets received of 10 milligram received from the patient. That entry will be made. That's how disposal of leftover doses is done. There is one catch. If the expiry date is over, then the law is clear. Any destruction will have to happen in the presence of a drug controller, drug inspector. You will have to inform them. They may say, okay, you may destroy it. That's supposed to be the process, but most people give a phone call and they give you the okay and do it, but it's better to get it documented. Mr. Pranab Basu a friend of mine from West
Thank you so much.
Bengal, asked, a cancer patient suffering from horrendous pain increasing highest dose of oral morphine. Does it depend on the immunity of the patient? No, the first question to the answer, there is no higher limit for the dose of morphine. I have heard of patients being given thousands of milligrams per dose, but in our practice, I remember a girl with a chondrosarcoma of the scapula and over the scapula, and it was visibly growing every day. It was an 18-year-old girl. She was initially on 20 milligrams, and we don't know if it was bleeding inside, it was growing. And over 1 week, the dose from 20 milligrams per hourly went up to 200 milligrams per hourly. But there is no upper limit to the dose. If the pain is there, that is the body's physiological antidote. There will be no undue drowsiness, there will be no respiratory depression. Does it depend on the immunity? I don't think so. The factor that it depends on is the extent of pain. The more severe the pain, the higher the dose. As simple as that. Thank you, Pranabji. Amitesh Pathak asks, buprenorphine versus Pendanal patch, how to choose? Okay, I'm Dr. Amitesh. I did not even mention buprenorphine. My apologies. Buprenorphine is not a step 3 medicine. It comes somewhere between step 2 and step 3. The difference between step 2 and step 3 is the ceiling effect. A ceiling. I said morphine dose, there is no upper limit. I cannot say the same thing about buprenorphine. Beyond a certain dose, it causes significant drowsiness, and especially in combination with benzodiazepines, I have seen respiratory depression be happening. So buprenorphine is not as the same class as fentanyl. Having said that, the majority of patients, if the dose of opioid requirement is not very high, can be managed on buprenorphine. It has the advantage that the patch will last for a week, as against just 2 days for Pendanal. In head and neck cancers, there is a limitation of neurolytic interventions. Oh yes, I started my pain management career by giving mandibular and maxillary neurolysis, horrible procedures. It did work in some patients, but the pain of the procedure is agonizing. So there is a great limitations. The management then mostly is on pharmacotherapy, the ladder. Sometimes in head and neck, there is also dysphagia. We like to switch over to rectal administration or a parenteral administration. There is no other choice. Dr. Isha, you are asking about transdermal buprenorphine versus fentanyl in relation to renally impaired, elderly, and immunosuppressed patients. Dr. Isha, maybe my knowledge and understanding is limited, but fentanyl is not excreted by the kidney and therefore is quite safe in that also. And about elderly and immunosuppressed buprenorphine being safer, honestly, I have my doubts, especially in the elderly. But one thing I'll tell you, especially in the elderly, be very careful about combining these opioids with benzodiazepines. Because especially in the elderly with buprenorphine then becomes slightly riskier because it acts for much longer. Duration of action is so much more. Fentanyl, if injection brief, even transdermal brief, you can manage that period of time. And finally, buprenorphine has one more disadvantage. If respiratory depression does happen, it is not easily amenable to reversal with naloxone. Therefore, I am Dr. Isha. I'll look again, study a bit more, but I really do not think, in the context of conditions you have mentioned, buprenorphine has advantages. Dr. Manan Mahavar again asks, injection morphine 2 milligrams subcutaneous dosage SOS. What we should do with the rest of the 15 milligram ampule should be discarded or can be used in a country with limited access. As he said, doctor, the law is not very clear about our using leftover medicine. Our pharmacy says no. If you open an ampule, a patient's name has to be given. But there is not a legally binding thing. The law is not doesn't say anything about that practice. I suggest Dr. Manan Mahavar, in consultation with the team, you should use your own. Dr. Amidesh Pathak wants to learn palliative care. Dr. Amidesh, I don't know if you took down the email ID that I gave. I'll give my email ID also in the chat box. We do have courses, Doctor. I'll give you information about it. Do please email me. My email ID is on the. Sorry, sorry. I gave you a wrong message. Please, there is a mistake there. The corrected email ID is given in the chat box. Please ignore the first one, palliavindia.org. Also, if you look at Palliav India website and go to training, you will see the various courses listed there. Please take a look, and by all means feel free to contact me. Anybody else, online courses are available. You don't have to take your time off from work. There are some courses that are only once a week for 1.5 hours, and it's easy to do that kind of foundation course online, virtual courses. Most welcome to join our courses. I'll tell you also, if you write about fellowships and various opportunities, including those abroad. The chat questions are over, Sarita.
Yes, sir. Thank you, sir. Now I invite Dr. Professor Arun Chaturvedi, sir, for a few words on this CME.
So, Dr. Rajgopal, I'm very thankful to you for presenting such a wonderful presentation. There was so much to learn in that presentation, and I also learned many things. So thank you for an excellent discussion on pain management. I think our postgraduates would have benefited greatly from your presentation. I do understand the importance of what you are telling. As a cancer surgeon, I do understand the importance of what you and your organization and what you have been spearheading has been doing all these years, and your tremendous leadership in this area. I wish you all my best, and under your guidance, I think so much is happening, and so many new places are taking up the lead in developing palliative care in the centers like we are doing. And the question answer session was very interactive, and I thank the audience for participating actively in the discussions. And overall, I felt this CME and this guest lecture has been excellent. So thank you once again, and we look forward to hearing from you again and hearing you again. Thank you so much. Thank you, Sarita.
Thank you, sir.
Dr. Arun, Sarita, everybody, thank you. This is a privilege to be with KGMU.
So now I would like to invite Professor Monica Kuliman to say a few words, ma'am. Ma'am, please.
You are muted, ma'am.
Good afternoon, everybody. Can you hear me?
Yes, Dr. Monica.
It was a wonderful talk. I've heard you before also, but every time it really becomes even better and better. And as you know, sir, Sarita is very keen to start the palliative course over here. So we really need your help, our HOD's help, our Vice Chancellor's help to start that course. So, and also we have started giving morphine. So we want to do a lot of sensitization to the staff nurses, to the paramedics, to the doctors. So we would really need your help, your blessings. Thank you so much, sir.
With you all the way, privilege.
Right. Thank you, sir.
Thank you for this opportunity.
Thank you.
Thank you, ma'am.
Now, I would like to invite Professor Ajay Chaudhary, sir, who will pose the vote of thanks.
Good afternoon to all. I consider a great privilege to propose the vote to all dignitaries who have witnessed and first of all, I would like to thank our chief guest, Honorable Vice Chancellor, Lieutenant General Dr. Discontinued. His adult guidance has always encouraged us. I thank him for his kind and continued support for our department. We are grateful to our invited faculty, Padma Shri Dr. M.R. Gopal, Director and Founder of Relevance, who despite his busy schedule has taken out time to grace this occasion with his history. We would like to thank our HOD, Professor G. Sir, for their support, vision and commitment. I also thank Chairperson Professor Anand Reddy Sir, Professor Muntaru, coordinators of the event, Dr. Sarthi, and on the guide, Secretary Dr. Manit Singh, for his hard work to make this event successful. Last but not the least, I would take this opportunity to thank all delegates, presenters who had taken out time for their busy schedule for this event. Once again, I thank you for your participation. Thank you.
Thank you, sir. Thank you very much. Thank you, sir.
Thank you.
Thank you.